Hi everyone, and welcome to our presentation on Mycobacterium tuberculosis. So here's a little outline of what we're talking about and who will be speaking today. So my name's Emily, and I'll be talking about the organism structure. Sarah will be talking about pathogenesis and virulence of Mycobacterium tuberculosis. Candace will be talking about the disease development, and Lindsay will be talking about the disease spread and treatment. So Mycobacterium tuberculosis exists as bacilli, morphology, and arrangement, although they have also been found in the arrangements of diplobacilli, which are two bacilli next to each other in a line, or palisades, which are several bacilli in a clump or cluster. Mycobacterium tuberculosis cells tend to be about 2 to 4 micrometers long and 0.2 to 0.5 micrometers wide. These organisms are non-motile and non-spore forming. The inside of Mycobacterium tuberculosis consists of the nucleoid, ribosomes, and cytoplasm, while the outer structures include the cytoplasmic membrane, cell wall, a capsule, and 2 different types of pili. The most important type of pili that you should know about are the coiled pili, as they are thought to contribute to the biofilm formation of this organism, as well as its adherence to the host cell and its ability to trigger host inflammation. This organism is an obligate aerobe, which explains why it's most often found in the well-aerated portions of the lungs, such as the alveoli. It's important to note that this organism cannot be gram-stained due to its waxy cell wall, which we'll talk about in the next slide. The cell wall of Mycobacterium tuberculosis is unique in its structure. It's unique because more than 60% of the cell wall structure is consisted of lipids. This fact is thought to contribute to its virulence factors. One of the most prevalent lipids in the membrane is mycolic acid, which are strong hydrophobic molecules that form a shell around the organism and have a large effect on the permeability at the membrane. The mycolic acid is what makes this organism acid-fast positive. The mycolic acid is also thought to contribute to the virulence factors of the organism, as it helps to make the cell impenetrable to oxygen radicals formed by phagocytic granules. Another lipid, known as the cord factor, is what causes colony growth and serpentine-like cording, as seen on the plate in the bottom left. When grown on plates, specifically Lowenstein-Jensen media, colonies appear to be irregular in form, raised in elevation, with lobate margins. The colonies have been described to look like cauliflower, as seen in the photo. The serpentine-like bending of the colonies is thought to only be produced by the virulent strains of Mycobacterium tuberculosis. In summary, the high concentration of lipids in the membrane are thought to contribute to many of the cell's attributes, including antibiotic resistance, impermeability to stains and dyes, resistance to extreme pH levels, as well as resistance to oxygen radicals from macrophages.
Mycobacterium tuberculosis enters the host through the respiratory tract via inhalation through the nose or the mouth. The droplets containing tuberculosis enter the lungs and travel to the alveoli within the lung. The pathogen adheres to the host organism using its pili. Once in the alveoli, these bacilli multiply and replicate intracellularly. Some of the tubercles enter the bloodstream and spread throughout the body to locations such as the brain, larynx, lymph nodes, lungs, spine, bones, or kidneys. Tuberculosis can lay latent in the body, so sometimes the body doesn't immediately react. Within 2 to 8 weeks, macrophages engulf the tubercle bacilli and form granulomas. Eventually, the bacilli become too much for the macrophage to contain and they kill it, breaking down the granuloma barrier, allowing the bacilli to multiply and continue to spread throughout the body. M. tuberculosis exits the host as droplets from the mouth by exhalation or coughing. Mycobacterium tuberculosis evades the immune system by killing macrophages and growing intracellularly. This process of dissemination primes the body's immune system for a systemic inflammatory response. So part 1 of the picture just shows the droplets entering the body through the nose and the mouth into the respiratory tract, and they travel to the lungs and then to the alveoli within the lung. And then part 2 just shows that the bacilli multiply in the alveoli. Part 3 shows the bacilli spreading in the blood throughout the body to the brain, the larynx, the lymph nodes, lungs, spine, and kidney, and even bones. It can reach any part of the body, and this is where you really notice the different effects and the severity of the disease. Part 4 shows the special immune cells forming the granuloma barrier and the macrophages to try to prevent the spread of TB. And then part 5 shows that the bacilli break down the granuloma and they escape and continue to go throughout the body. M. tuberculosis has a complex lipid structure in its cell wall, as well as the ability to stimulate a strong cell-mediated response. The lipids lead to impermeability and resistance to antimicrobial agents. Tuberculosis causes extreme inflammatory responses, which can lead to severe tissue damage. It has also been found to trigger apoptosis or cell death of alveolar macrophages. TNF-alpha is a cytokine produced by the host's immune response that is crucial to controlling the infection. It helps to restrict dissemination of the organism throughout the host. A study performed on mice showed that if too little TNF is present, the host is not able to prevent dissemination, and if too much TNF-alpha is present, severe lung inflammation and early death can occur. This is a lose-lose situation for the host. So again, this slide just shows some of the virulence factors which really come into play from the complexity of the lipids that Emily talked about. And the image again shows the host where the droplets come in through the mouth, into the respiratory tract, in the lungs, where they reach the alveoli, and then the macrophages begin to form in response, which leads to the formation of granulomas that form the barrier. Eventually, the bacilli within the macrophage become too much and they kill it, and it breaks down the granuloma, where then TB spreads and it is transmitted out of the mouth.
Tuberculosis, while inside the body, can reside in one of two ways, either active or latent. Latent TB does not show signs or symptoms and cannot be transmitted to others. Signs and symptoms of tuberculosis are only displayed when TB is active. These include a prolonged cough over 21 days, coughing blood or sputum, fever, tiredness, chills, sweating, or painful breathing. In this bottom diagram here shows how tuberculosis can affect different structures, breaking it down from the host, organs and tissues, as the granuloma, like Sarah said, the cells, and then the subcellular level. For cytopathic effects, first, tuberculosis is inhaled by the respiratory system through the mouth or the nose to gain access to the internal surface of the host. The macrophages and dendritic cells then take in the TB molecules by engulfing them. Remaining TB molecules will migrate to the alveoli, where they attack the lung epithelium. The TB organisms cause their host to begin an inflammatory response, which brings immune cells to flood to the area. The surplus of cells promotes the bacterial reproduction and growth of tuberculosis. In this bottom left corner, we have a picture of tuberculosis, and the bottom right has a diagram of cytopathic effects in general regarding apoptosis, necrosis, and execution. For long-term effects, research has contributed to the exploration of long-term impacts on a body with tuberculosis. In this slide, there are some basic statistics found in just 2 of the many studies. So in 68% of diagnosed TB cases, according to a study in South Africa, people were found to have impaired airflow. While different studies were found in different environments, there were many in America, many outside of the US, they all generally concluded that tuberculosis can have an impact on the airway and impair breathing for people over time.
For disease spread of tuberculosis, it is spread in droplet form through the air. Someone infected with TB can cough, sneeze, or talk, and another person can then ingest that droplet to contract tuberculosis. The droplet travels from the mouth or nasal canal into the upper respiratory tract, then into the bronchi, and finally the alveoli. So the pictures here once again show a person who has TB spreading the droplets and another person ingesting those droplets to contract tuberculosis. The picture in the bottom shows the bacteria in the lungs in comparison to the bronchi. For diagnosis, prevention, and treatment of tuberculosis, tuberculosis is diagnosed by a TB skin test or a TB blood test. The skin test involves injecting the patient with a small amount of tuberculin into the skin of the lower arm. 48 to 72 hours later, the arm is examined by a healthcare professional for a reaction. A positive reaction results in hardened, swollen, or raised injection site. So that's the picture in the bottom left. It shows the needle injecting the tuberculin into the layer of the skin. And then it shows after the designated time how it reacts in the body. So if that person does have tuberculosis, you can see the injection site becoming raised, swollen, and having color to it. The other test is a blood test, which involves blood being drawn from the patient and examined by a lab to confirm if the patient has the TB germs. Further testing and exams are needed to diagnose if it is latent or active. Tuberculosis is prevented by avoiding contact with known TB patients, covering your mouth when sneezing or coughing, having good air ventilation, and having good hand hygiene. Tuberculosis is treated by a course of antibiotics. The length of time depends on if it is latent or active and your health condition. Medications can last from weeks to months. So in a severe case, it can last from 9 months up to 1 year. And so the last picture here shows the bacteria that is found in the lungs. And so lastly, we have